Hello. My name is Dr. François Ricard. I am an osteopath and a PhD. I am director of the International Madrid School of Osteopathy, EOM, and president of the Scientific European Federation of Osteopaths, SCFO. In this video, I want to talk to you about mechanical mechanism of action for HVT in the spine. This series of videos will look at the scientific literature surrounding the mechanisms of spinal manipulations, mostly used by osteopaths and chiropractors. In these videos, we will study the mechanical mechanisms of action for disc hernias, and the effects they have on the peripheral and central nervous systems, the neuromuscular, biological, and neurovegetative systems, and on the organs. In this first video, we are reviewing the mechanical mechanisms of action of high-velocity manipulative techniques, HVT. Herzog et al. 1993 indicate that peak and preload forces vary depending on the location of treatment on the spine. Herzog et al. 1993a. According to Herzog, 2010, the thrust duration is approximately 100 milliseconds for cervical treatment, and 150 milliseconds for thoracic and lumbar treatment. According to Triano, 2000, spinal manipulation with HVT in chiropractic treatment involves bringing the facet joint to the end of its range of motion. The thrust force takes the facet joint beyond its regular end range of motion, into the paraphysiological movement zone. Note: using the minor movement parameters to apply tension, HVT manipulation in osteopathy is carried out in the middle of the physiological range of movement of the joint. According to Herzog, 2010, the force applied during a manipulation is similar for men and women. Spinal manipulation produces significant relative movements, primarily between the targeted and immediately adjacent vertebrae, during the preload phase, as well as an additional relative movement in both during the thrust phase. When the thrust is applied, it produces a movement in the facet joint that goes beyond the movement produced by the preload force. In this graph, we see the difference in sagittal rotation of approximately 2 degrees during the thrust movement, which indicates a vertebral movement in the paraphysiological region. Herzog et al. 1993 indicate that peak forces are considerably smaller for spinal manipulative therapy performed on the cervical spine, around 100 newtons, compared to corresponding values obtained on the thoracic and lumbar spine, as well as the sacroiliac joint, all around 400 newtons. Furthermore, treatment forces varied significantly between operators, with maximum forces that range from 200 newtons to 1,600 newtons. Herzog et al. 1993, the upper end of the range being 8 times higher than the lower end. According to PICKAR and BOLTON, 2012, force time profiles may be characterized by a preload phase, a thrust phase which rapidly rises to a peak force, and a resolution phase. The characteristics of these profiles appear to vary, depending upon region of the vertebral column to which they are applied. Manipulation applied to the cervical region has relatively little preload, ranging from 0 to 39.5 newtons. Herzog et al. 1993, Korchuk et al. 1992. The resolution phase lasts between 90 to 120 milliseconds, average equals 102 milliseconds. The thrust phase lasts between 30 to 65 milliseconds, average equals 48 milliseconds. The peak force is between 99 and 140 milliseconds. In the thoracic region, T4, peak force lasted 150 milliseconds plus minus 77 milliseconds, and the average peak force reached 399 newtons plus minus 119 newtons. The peak force during manipulation of the lumbar spine, measured by Triano and Schultz, 1997, tended to be higher than during the thoracic or sacroiliac manipulation. When spinal manipulation was applied to the sacroiliac joint, mean applied peak forces reached 328 newtons plus minus 78 newtons, according to Herzog et al. 1993, with the thrust and resolution phases having similar durations, 100 milliseconds. This graph by Herzog, 1993, demonstrates the differences in force and time between spine manipulations with HVT applied to the cervical, thoracic and sacroiliac regions, with the use of an activator. As expected, the level of force was lower for the cervical spine, and with the activator. During a toggle recoil manipulation, force varied by up to 100%, and displacement by up to 50% according to CRAMER et al., 2010. Hsieh et al., 2012, have shown that ultrasonography is a reliable instrument for the assessment of somatic dysfunction of the lumbar spine, and for proving facet joint opening with HVT. This diagram by CRAMER et al., 2011, presents the theoretical mechanism of cavitation, i.e. joint pop sound, production during a spinal manipulation. Drawing A is a sagittal view of the zygapophyseal joint, showing Z-joint synovial folds. Drawing B shows zygapophyseal joint adhesions developing in a hypermobile joint. Drawing C shows therapeutic gapping, opening, of the zygapophyseal facet joint breaking up adhesions, while a cavitation, pop, is created. According to Evans, 2002, HVT manipulation causes the release of entrapped synovial folds or PICKAR, and sudden stretching causes the relaxation of hypotonic muscle. HVT manipulation also disrupts articular or periarticular adhesions, and corrects abnormal segmental motion. The study by Harich, 2017, showed that the path to joint cavitation is the same for asymmetric separation of the joint surfaces in the cervical spine and the metacarpophalangeal joints. CRAMER et al., 2012, indicate that lumbar spine manipulation produces cavitation, a facet opening of 0.69 mm. The opening is larger in men than in women, 1.01 versus 0.49 mm, p less than 0.002. In general, joints in which cavitation occurs open more than those with no cavitation, 0.56 versus 0.22 mm, p equals 0.01. According to Van Jet et al., 2017, when cavitation occurred, individual subjective experience ratings were higher, suggesting that participants may associate cavitation with the success of manipulations. Higher practitioner seniority, more years of experience, induced feelings of higher speed, amplitude, firmness, and precision. According to CRAMER et al., 2010, hypomobility results in time-dependent adherence development within the facet joints. Spinal manipulation could break up zygapophyseal joint intra-articular adherences and restore normal mobility. This slide explains the theoretical mechanism of cavitation, joint pop sound, according to CRAMER et al., 2011. In this sagittal view of the zygapophyseal joint, which shows the synovial folds, A, we can see the interfacet joint adhesions, which develop in a hypermobile joint, B. Therapeutic gapping, opening, of the facet joints break up the adhesions while creating a cavitation, pop. In this MRI, CRAMER et al. Found a greater opening in the facet joints that were treated with a manipulation with HVT, 0.5 mm, compared to joints that were not treated with HVT, 0.2 mm. In vertebrae with cavitation, the joints separated more than in vertebrae with no cavitation, 0.8 mm versus 0.4 mm. Hsieh, 1994, indicates that cavitation produced by spinal HVT has several main effects. According to Bogduk and Joule, 1985, spinal manipulation releases synovial folds or trapped plicae. The opening of the facet joint releases synovial meniscus and suppresses the distension of the joint capsule, thereby reducing the pain. According to several authors, HERZOG, 1993, Gillette, 1986–1987, Katovich, 1998, Kaur, 1975, Indal, 1997, relaxation of the deep hypertonic muscles occurs with sudden stretching. The mechanoreceptors of the joint capsules produce reduced spontaneous paraspinal electromyographic activity. Hsieh, 1990, and Vernon, 1992, indicate that spinal manipulation produces alterations to central sensitization, and reduces paravertebral hyperalgesia by increasing the paravertebral pain threshold. Brennan et al., 1989–1992, have indicated that cavitation acts on the cells that make up the immune system, increasing the level of polymorphonuclear neutrophils and plasma concentrations of substance P. It releases articular and periarticular adherences. It also affects disc herniations. Duggelly et al., 2015, observed that after a cervical manipulation, maximum range of motion was 39 degrees in side bending, 21 degrees for axial rotation, and 8 degrees for flexion extension. During the thrust phase, the average range of motion was 8 degrees for side bending, 5 degrees for axial rotation, and 3 degrees for flexion extension. The average of axial rotation and side bending ratio was 0.6 for global movements, pre-manipulation position and thrust. The helical axis displayed an oblique orientation, with a location ipsilateral to the impulse side, and opposite to the thrust direction. The study by Buzzati et al., 2015, shows that a thrust applied to C1 produces an average facet joint displacement of C1, relative to C2, of 0.5 mm. The maximum displacement, representing a global movement of the facet joint from a neutral position to its final position, is 0.6 mm. The displacement induced by applying HVT to the upper cervical spine seems not to endanger either the spinal cord or the vertebral artery. In the study by Anders et al., 2018, the opening of the facet joints increased by 0.9 mm during a cervical manipulation. The average rate of separation of the facet joints was 6.2 mm per second. The peak force, and rate of force application during manipulation were 65 newtons per second and 440 newtons per second. Pain score improved from 3.7 before manipulation to 2.0 after manipulation. Intervertebral range of motion increased after manipulation by 1.2 degrees to 3.9 degrees in flexion extension, 1.5 degrees to 1.9 degrees in rotation, 1.3 degrees to 1.1 degrees in side bending. Global head range of motion, relative to the torso, increased after manipulation by 8 degrees in side bending, 10 degrees in rotation, and 13 degrees in flexion extension. The results demonstrate that target and adjacent motion segments undergo facet joint gapping during manipulation, and that intervertebral range of motion is increased in all three planes of motion after manipulation. HERZOG, 2010, measured EMG activity within 200 to 400 milliseconds, following the onset of the treatment thrust. Muscle activity disappeared following the treatment thrust, and was not observed during preload application, suggesting that this was indeed a reflex response, and that the reflex response was associated with the speed of force application. According to Cao et al., 2013, spinal manipulations with HVT produce sustained changes in peripheral neuronal signaling, due to altered load transmission to a sensory receptors, and local mechanical environment, are often considered a mechanism contributing to the therapeutic effects of spinal manipulation. Thrust displacements applied during an HVL spinal manipulation produced sustained increases in the resting discharge of paraspinal muscle spindles, regardless of the duration over which the thrust was applied. Conclusions. Forces applied to the spine during manipulations with HVT, preload, thrust, and post-manipulation relaxation, produce opening of the facet joints and cavitation, responsible for pop sounds. Facet joint opening stretches the joint capsule, and releases the facet adherences, as well as possible entrapment of the synovial meniscus, producing reflexes that modify abnormal neuromuscular functioning, and nerve sensitization. It has proven immunological and endocrine effects. HVT spine manipulations increase segmental and global range of motion by releasing the facet joints. They modify the normalized EMG value. Hereunder, you can see a list of all the references used for this presentation. Thank you for listening.